Rickets. The most common cause of rickets is vitamin D deficiency. Vitamin D can be deficient due to nutritional cause, which is in fact the most common cause of vitamin D deficiency. And there is liver and renal failure, and also there is lack of sunlight exposure. As the vitamin D is deficient, there will be decrease in mineralization of the bone and the bone becomes weak. Now coming to the laboratory finding of rickets. As all of us know, vitamin D increases the serum calcium level. It increases the serum calcium level by three ways. In the gut, it increases absorption of calcium. In kidney, it decreases excretion of calcium. And in the bone, it increases bone resorption. So, it is very clear that due to deficiency of vitamin D, there will be hypocalcemia. So, in rickets, there will be hypocalcemia or normal serum calcium level. Now, why normal? I am explaining you in a minute. Vitamin D gives negative feedback to the parathyroid gland. Now, in deficiency of vitamin D, this negative feedback effect won't be present there. So, there will be increased amount of parathyroid hormone secretion from the gland. Now, as the parathyroid hormone secretion increases, it increases the serum calcium level. Also, it decreases the phosphate level in the blood. It also causes resorption of bone. Thus, it normalizes the serum calcium level. Due to increased amount of bone resorption, there is increased amount of osteoblastic activity. Thus, the level of alkaline phosphatase elevates. So, the lab findings are hypocalcemia or normal serum calcium level, hyperparathyroidism, elevated level of alkaline phosphatase, and decreased phosphate. Now coming to the clinical findings of rickets. In skull, we get softening of the skull bone, which is also known as craniotabes, which in fact the earliest change in rickets. Next finding is frontal bossing or prominence of frontal bone. Next finding is delayed closure of the fontanelles. Now let's come to the chest findings of rickets. First finding is ricketic rosary, which is swelling of costochondral junction. In the picture, you can see the costochondral junction has swelled up. The swelling is blunt and non-tender, which differentiate it from the scorbutic rosary, which is a tender swelling. The other classical findings of chest is Pigeon chest, also known as pectus carinatum. Here, the patient's sternum becomes prominent. Due to calcium resorption, the ribs are softened. And as patient breathes, the ribs are pulled inside. and the sternum becomes prominent. Next is Harrison's sulcus, also known as Harrison's groove. It is a horizontal groove along the lower border of the thorax corresponding to the costal insertion of the diaphragm, as you can see in the picture. Now coming to the long bone findings, the features become prominent during work after putting weight on the long bone. These are coxa vara. In this condition, thigh moves medially distal to the hip joint. Next is genu valgum. In this condition, leg distal to knee goes laterally. And in genu varum, leg distal to knee joints goes medially. Say this is picture number 1 and this is picture number 2. In picture number 1, this is hip joint, and from the hip joint the thigh has moved medially. So this is a case of coxa vara. And this is knee joint, and legs distal to knee joint has moved laterally. So this is a case of genu valgum. In the second picture, the legs has moved medially distal to the knee joint. So this is a case of genu varum. Next deformity is wind-swept deformity. In this deformity, one leg is in genu valgum and the other leg is in genu varum. This leg is in genu valgum and the other leg is in genu varum. It is called wind-swept deformity as it seems like a strong wind has blown from this side. Now coming to the joint findings in rickets. There is swelling of joints, as you can see in the picture. This is due to interstitial growth of bone at the growth plate. Growth plate has several layers. Number 1, germinal layer, where the bone cells are born. Number 2, proliferative layer, where the cells are multiplied. Next is hypertrophic layer, where the cells grow in size to accommodate calcium. Fourth is layer of calcification, where the cells are calcified. Fourth is layer of calcification. And the last layer is layer of ossification, where the cells become part of normal bone. In rickets, the hypertrophic layer is defective. So, they are not calcified. And they continue growing and they pushes the metaphysis. Say this is end of a long bone and the hypertrophic layers continue growing and pushes the metaphysis, causing cupping and splaying of metaphysis and widening of the epiphyseal plate. In this picture, this is a normal x-ray and you can see there is very less gap in the epiphyseal plate, but in rickets the gap has increased. So there is increased gap in the epiphyseal plate in ricket. Also, there is cupping of metaphysis and splaying of the metaphysis. Now, if you give calcium and vitamin D to this patient, bones begin to mineralize and the calcium deposition appears as white line in the bone in the X-ray. If you notice in this X-ray plate, these are the white line of calcium deposition. This is called healing rickets. Now, after calcification, osteoclasts reverse the abnormal swelling in the joint.